Suzanne Huber is the Assistant Administrator of the Golden Manor Home and Services for the Aging here in town, and has a unique background because you're both a social worker and a nursing facility administrator in terms of your training, so that makes her particularly unique. And therefore, any questions you have left over from the presentation before, for example, or any of the other ones about nursing home residents, she is the woman to ask. And she's going to give you a talk today. You already have, it's a one-sheet outline handout. She doesn't need slides, so we're set. Thank you.
Thank you, Michelle. Is there anybody here who works in a nursing home? Anybody who's ever visited a nursing home? Okay. Let me tell you first a little bit about Golden Manor. Golden Manor is an 80-bed, not-for-profit, Jewish nursing facility. We've been in existence since 1968. We're rather unique in that we have mostly private rooms. We're a kosher facility, meaning that we follow the kosher dietary laws. We have 2 kitchens, meat kitchen, dairy kitchen. All of our residents, if they come to our facility, do follow a kosher diet, whether they're Jewish or non-Jewish. I've been with Golden Manor for 6 years. As Michelle said, my background is in social work, and I recently went through the nursing home administrators course and took the test and got licensed. And I've been assistant administrator at Golden Manor for 2.5 years. Previous to that, I was in home care. And so I have the advantage of kind of seeing the elder at home, services they need at home, and transitioning into a long-term care facility. Now, I want you to remember that only about 13% of the population ever goes into a nursing home. So we're talking about probably a smaller percentage of the population than you may be thinking of. What occurs to cause a person to go into a nursing facility? Generally, there happens to be a major event in that person's life. Major event may include a fall, and that fall may be a result of a stroke, of a heart attack. The fall may be secondary to the primary reason the person fell. It may be due, as I said, to a CVA. The person may have had a stroke. At Golden Manor and other facilities in San Antonio, we see a lot of stroke victims. Maybe due to a terminal illness such as a cancer, end-stage congestive heart failure. Might be due to Parkinson's. We have a lot of residents who have end-stage Parkinson's. And then, of course, that's coupled with dementia, and maybe they've had a CVA. Generally, multi-systematic, multi-systems are affected. And finally, they may have some sort of dementia that may be associated with a stroke or may not be associated with a stroke, maybe Alzheimer's, maybe multi-infarct dementia. But I would say 90% of our residents do have some form of dementia, either short-term memory loss, long-term memory loss. Some of our folks are bedbound, nonverbal. And if the person is with us long enough, we may see the progression of someone who is ambulatory, hearing fine, eating on their own, etc., to a bedfast patient that is nonverbal. And we have several of those. We tend to have long-term stays at Golden Manor. We had someone who was 102 that recently passed away. She'd been with us about 12 years. We currently have about 11 of our residents on hospice. And some of those are most end-stage congestive heart failure. A few people have cancer, and some of them are stroke victims. So how did this person come to Golden Manor? Well, generally, an event occurs, such as a stroke, fall, broken hip, broken knee, knee replacement. They end up in the acute care hospital. And after the acute care hospital, they're generally referred to a SNF bed or rehab bed. Now, Golden Manor does have rehab beds. We do rehab. We have SNF beds. So does RIOSA. So do a lot of the facilities in San Antonio. There are 51 facilities that accept Medicare. And so there are 51 facilities that will do Medicare A or rehab. So the person leaves the hospital and goes to a facility. Now, the first thing you have to decide, and generally it's in a matter of 24 or 48 hours, is where that person is going to go. At Golden Manor, we'll have calls from case managers from hospitals. Family members will call. It's rare that the person themselves will call, but we'll get a referral and expect to place that person pretty quickly. That's really a problem for us and a family member, because we don't like to admit on a 24-hour period basis. We don't get to assess the resident properly. The family doesn't get to tour. We don't get the proper information that we need to make an educated decision. So it's very stressful on the families, and certainly on the residents, and also on the case managers who have pressure to get them out of the facility, out of the hospital as soon as possible. But if it were a perfect world, a family member or someone who's thinking about going to a nursing home would do their research. The first place I would recommend, with a grain of salt, is the Medicare website. Now, I've run a report off the computer from www.medicare.gov, and I compared 4 facilities in San Antonio. Our facility, Morningside Manor, Tri-Sun, and that's all, 3 facilities, I'm sorry. And I'm going to pass this around so you can look at this. And what it will do is compare the facilities as to quality indicators. Now, quality indicators are something that CMS or Medicare uses to grade a facility. We send information in on incontinence, number of falls, level of pain. There are several variables that you'll see, and we get rated. We were recently voted most improved facility in our area, basically because we got our Medicare grade up. We're currently at 88, and I think we're the 5th highest in our region. Now, that is, the grain of salt comes, we send the information in, and CMS processes it, compares it to other facilities in Texas and the United States. We're sending the information in. Medicare is not coming to our facility to look to see if this person is incontinent, if we have a bladder schedule for this person. It's self-reporting. So be that as it may, it's still, I think, the first place to start. You get a good idea of a facility, and you get a good idea of problems that may be going on in that facility. The second grain of salt is that these figures are old. These are usually 6 months behind or a year behind. So I may get a call from a family member, well, I hear you have a problem with impaction. And this is a true story. And I said, well, we don't have a problem with impaction. I'm not sure what you're talking about. And he referred to the Medicare website. And 2 years ago, survey team came in, and there was a resident that had chronic impactions, and apparently the nursing staff didn't deal with it appropriately, so we got dinged for it. We got a deficiency for it. So that information is very old and not up to date, and is probably an aberration of what goes on in our facility. So I'm sure the same thing goes on in ABC facility here in San Antonio. So start there. It'll give you a good listing of the facilities in our area. It will give you their last survey results. State comes in once a year to do their survey. That's Department of Aging and Disability. They send a team in of 7 or 8 people, comprised of nurses, dietitians, someone that's going to survey pharmacy, and like safety code, they survey the building. So they're looking at everything. So it's pretty comprehensive. It's like JCO. You may be familiar with JCO. Except the surveys are unannounced. We never know when they're coming. So that's your first source. The best source of information is to go to the facility and tour at odd hours. Certainly you need to make an appointment with an admissions person and go and get the marketing spiel. But it's important to go to the facility after dinner, during a meal, early in the morning, and certainly on the weekend, so you can see what's going on with the residents at that time. Generally, we're very well staffed during the week. But people may run short on the weekends. And it's going to be very important to you as a family member to make sure that your loved one is cared for. Payer source. What's going to really determine a decision to go into a certain long-term care facility is going to be the payer source. Most people in our market have Medicare and maybe a secondary insurance like ARP or Blue Cross Blue Shield, a lot of the federal employees. TRICARE we see a lot because of the military. So they come in, Medicare is going to pay for their first few days because they're coming in all skilled, and then after that, how are you going to pay for your bed? Our price at Golden Manor for a private pay bed is $5,018 a month, and it's actually going up in a couple of months. We do accept Medicaid. To be eligible for Medicaid, you have to file an application with the state, and you have to be financially eligible as well as meet their medical necessity. And what medical necessity means is you need assistance with your activities of daily living, you can't take your medications, a certain amount of incontinence, things of that nature. Now, another payer source exists, and that would be a Medicare Replacement. And right now, in our region, Secure Horizons is a Medicare Replacement, Humana Gold, and I think that's all that's in, and then there's VA contracts. Now, Golden, we don't have a contract with Secure Horizons, but Medicare does, Trison Babcock does. So if you have Secure Horizons, you're more likely to go to those facilities that have a contract with the Medicare Replacement. Now, next year that's going to change because we're getting you probably had a session on this. We're getting a drug benefit, Medicare recipients. It's called Medicare D. Have y'all had a workshop on that yet? You know that we have a drug discount program now. But as of January 1, Medicare recipients will have a drug benefit. And you know, you have Medicare A, that's inpatient hospital, Medicare B, that's outpatient, and Medicare D is going to be your drug benefit. Now, if you go into healthcare in the near future and work with Medicare recipients, it's going to be chaos and mayhem. And the reason why is that it's privatized. The D benefit is going to be privatized, and there are going to be 30 to 35 programs available to seniors, drug benefit programs. Now, if you're not signed up for one by May 1 of '06, you automatically get assigned to a program. Medicaid will no longer pay for medications. Medicare will take over that responsibility. So in a long-term facility where we have a Medicaid resident, Medicaid pays for the meds. Actually, we do, and Medicaid reimburses us per diem. But Medicaid will no longer do that. It's going to be Medicare D, and everybody will get a different program. And the trick to signing up for the appropriate program is to see what medications you're on and what formulary is going to fit your medications. They're saying that this is going to be as revolutionary as when Medicare first came into existence. There have been some publicity out. There's some letters now going out from CMS, but we're gearing up to a lot of elders not opening their mail, not understanding what's going on, and not signing up for their drug benefit and missing the vote completely, and just getting assigned to program A, B, C, or D. So those are the issues that a family or a person might face when going to a long-term care facility or choosing a long-term care facility. So after they've made the choice and they're transferred to the facility, there's some things that we can predict happening. One is generally we see a month to 6 month transition period into the facility. If you haven't lived in an institution before, it's very difficult. We tell them what time they're going to eat their meals, what they're going to eat for their meal, when they're going to bathe, when they're going to go to the bathroom, when they're going to go to an activity, what that activity is going to be. There's a great sense of, or a great loss of freedom. And that likely leads to some depression, some acting out in some cases. And acting out, I mean verbal aggression, physical aggression, Falls increase. When we admitted 20 new residents in April, and our falls increased substantially. And this was because they were all on the wing that these new residents were admitted. So those are issues. Another, I tell families sometimes it's harder for the families to accept putting their loved one in a nursing facility than the person themselves. The family, once the resident is in, the family tends, if they're concerned family members, they visit quite often. They have lots of concerns, lots of complaints. They are not used to the routine. We may have a family member, threaten to call the state because of some misunderstanding. Generally, it takes as long as them to transition as it does the resident, and maybe not at all. We do have family members that are inactive, that never visit, that maybe they come by to pay the bill, and that's it. For those residents, we try to create a family. Golden Manor is, we consider Golden Manor our residents' home. They're allowed to bring in their own furniture. They're allowed to bring in pictures. There's certain things they can't have, such as rugs, things of that nature. But we encourage them to make their room their home, and that's something that all of our employees must believe in, because it is their home. We're just allowed to work there. So besides having a home-like atmosphere, I think that a good activities director makes a good home. We have an activities director that works with all level of care residents, no matter how high the acuity. She may do a tactile sensation with a bedfast nonverbal dementia resident. She may play Uno with a group of residents that are unable to count, but they can see the colors and they can do things. So it's very important to make each resident feel welcome, and to find something that will motivate them, will provide socialization, how minimal, and will make them feel like that they're in a loving, caring environment. We had, I'll tell you a few stories about Golden Manor and transitioning to the facility. We had a gentleman, he and his wife came into the facility about 3 years ago, and she was dying of cancer. And that's really the reason they came in. She was quite ill. He was very distraught. And this is a Jewish couple. But they were secular. They were not practicing. And their sons are Orthodox, very Orthodox. They belong to the Chabad, and which doesn't really matter, except that they're very observant. So anyway, we have this family. She's dying. The husband is just distraught, and their sons are calling rabbis in Brooklyn to see what they should do. Just to give you an idea of the multifaceted issues that we have to deal with. So they're calling the rabbi in Brooklyn to see if they should put the mother on hospice, what they should do with the dad, should they withdraw, should they put a feeding tube in, et cetera, et cetera. So after the team meets, social worker, the rabbi here in San Antonio, the rabbis of Brooklyn, et cetera, we finally come to a decision with the family that they're going to put her on hospice, that they're going to let her have a quality end of life, free of pain, comfortable, et cetera. So she passes away, and then the husband, the widower, is still in Golden Manor, and they happen to the sons buried their mother. Well, the family, the mother and father, had made a pact that they would be cremated. Well, cremation is against Jewish law. And so he's just distraught for 6 months that his sons, buried the mother, and she was supposed to be cremated, and they went against the father, et cetera, et cetera. So this man was depressed. Not only was he grieving the loss of his wife, he was grieving that the sons did not follow her wishes after life. So he becomes suicidal. He tries to cut himself in his room. We have to take his letter openers away. He ends up going to a inpatient psych unit for about a week. And he comes back home, and he does okay. He's on, some psychotropic medications. He's being followed. And by the way, he doesn't have a traditional. He has a Medicare HMO and Medicaid, so he's got it. It's complicated on his payer source. A lot of times we can't find resources for him because they have to take Humana Gold, and not everybody takes Humana Gold. So not only do we have these family problems, the problems with psychological issues, being suicidal, it's hard for us to find resources for this man because of his insurance. So a year passes, and we admit a woman from acute care hospital. She had actually starting in on some dementia. She had a fall, typical resident. She comes in for skilled care, and moves in next door to him. Well, the first ice cream social that we had after she moved in, it was love at first sight for these residents. So, I can't say his name, Mr. Katz and this woman, Benny Fay, met, and a few months later we had a commitment ceremony for them. Now, we didn't have a marriage because it would have interfered in their benefits. He was on Medicaid, and she had money, and so that she had military benefits. So we had this commitment ceremony, and they have been married in a sense for, it's going on a year this summer. So that's an example of a story of some of our residents at Golden Manor. And that's not unlike a lot of residents in nursing homes. Just because you're in a nursing home, you still have a life, you still may have sexuality, you still have feelings, you have things that go on, you may have dementia as well. So we have very complicated residents. All of the facilities do. We're complicated now. We just become even more complicated as we age, and our body falls apart, and our mind may fall apart. Long-term care facilities are there to help those that need that help. Okay, so changes in condition. Now, this Mr. Katz has been there 3 years, and actually he's doing okay. He's doing fine. But the typical resident is going to just function of age, function of deterioration of the disease process, et cetera, there'll be a change of condition at some time. And that change in condition may be a fall. It may be a new diagnosis. It may be, you might find that someone has a cancer somewhere. We had 2 different female residents that were found to have breast cancer recently. So things, really don't remain static as in life. So if there's a change of condition, then we have to respond. The treatment team, which is the nursing staff, the dietary staff, the social worker, administrators, et cetera, and any kind of consults that we have working with them, will meet and formulate a new, what we call, care plan. So when there's a drastic change, the person may be put onto hospice. Now, generally we think of hospice as people going out to the home and providing palliative care to their patients, pain medications, medical equipment, things like incontinence materials, things like that, the hospice will pay for. But hospice also goes into nursing facilities. And there is some controversy in that. Some people believe that hospice in a nursing facility is a duplication of services. Because, we're, Golden Manor, we're providing incontinence care, we're providing medical equipment, we're providing medications, et cetera, et cetera. So there is a debate and there is an issue with that. And I share that with families when they're deciding to go on hospice or not, because they're going to get an explanation of benefits. An explanation of benefits is generally, if you've ever been to a doctor under your insurance plan, you've gotten one of these. Basically, it says, what was done, how it was coded, and how much the insurance paid. Well, they'll get an explanation of benefits from Medicare, and it may be $3,000 to $4,000 a month. under hospice benefit. So they're saying, well, hey, I'm paying $5,000 a month, and then Medicare's paying $3,000 a month, it's $8,000 a month for this resident. So some families have actually opted out of hospice after they've started because they don't believe it's really necessary. Now I tell families, hospice in a long-term care facility, the advantages to that is that they do have a nurse coming 2 to 3 times a week who is an expert in palliative care and pain management. We don't have that at Golden Manor. We have palliative care plans, we have good nurses, we have LVNs, RNs, but these people are specially trained and they deal with it every day. They also have quicker access to the doctors. We can have a hospice nurse come in, evaluate or assess a resident, then call the doctor, get an order, and get the med out in an hour. It may take us, depending on the doctor, 8 hours for the doctor to call back. If they call back, we have to call the pharmacy, have it ordered, have it brought over. It may be 24 hours before we can get the medication. So, and that's unfortunate, but that's the reality. So you can get quicker service, so to speak, with a hospice benefit. You can also get, you can get, I'll just say, fancier medical equipment. And what I mean by that is, I explained to you that Golden Manor is a not-for-profit charitable organization. A lot of our equipment is used or hand-me-down. Someone passes away, we give their wheelchair to someone else. We can't afford, expensive KCI beds, $6,000, $8,000 a pop, $25,000. We can't afford a lot of the equipment that a Medicare hospice agency can afford because they're billing Medicare. So that's another advantage. And another advantage is they do pay for their meds. The medications that are tied to their diagnosis, their Medicare benefit through hospice will pay for that. So it takes the burden, some of the financial burden off of us and puts it on their Medicare. So in some ways, we advantage financially for someone being under hospice, and also indirectly we're advantaged financially because we're having staff come into the facility seeing our residents that we're not paying for. So there's motivation on our part, to use hospice in a nursing home setting. We can't afford an extra social worker to come and work with the family. We can't afford, a chaplain to come in and meet with the family. We can't afford a lot of the things that Medicare hospice does provide. So it's a double-edged sword, so to speak. But I have to say we have 2 contracts currently at Golden Manor, one with Vitas Hospice and one with Santa Rosa Hospice. And they're both very good. We give residents a choice. And as I said, we probably have about 10 of our residents on hospice. I think that Dr. Sanchez-Riley is going to talk more about hospice in your next session. So that's changes in condition. Let me touch a little bit on DNR status and advanced directives. I don't know if you have had any sessions on that or are aware of what they are. Do not resuscitate. Most of our residents are DNR status. I would say the average age of resident Golden Manor is probably about 92. And so they are, generally speaking, at the end of their life, and they don't want to cycle back and forth to the hospital. They don't want to, be revived with CPR. And so in our facility, if you look on the rooms, we have little butterflies signifying that they're DNR. And if they're not, then they have a heart. But we have a significant number of residents that are not DNRs because of different cultural and religious values. They feel like that they should be kept alive as long as possible, as long as there's a way. Finally, discharge from Golden Manor or from any facility. Most of our patients are discharged to a funeral home. We have very few patients that go home. I would say probably this year we've had 4 that have come in to rehab and have stayed for maybe, there's a 100-day benefit for Medicare when you come in for skilled days. So maybe they stayed in for 90 or 100 days and they transitioned home. But most of our residents come in and they stay with us long-term, and they're long-term care residents. Now, I would have to say that the trend is not to provide that care due to the high cost and the Medicaid cuts. The trend is to open rehab units where people come in and stay for their 20, 80, 100 days and then go home. Medicare reimburses, for example, $250 a day. Medicaid reimburses anywhere from about $80 a day to $110 a day. For instance, at Golden Manor, the cost per day per resident is about $150 a day. So we're losing, depending upon the resident, about $40 a day on a Medicaid resident. And our facility is probably 60% Medicaid. So we depend upon donations, and the Jewish Federation gives us a stipend every year to make our payroll and to be able to survive. But the trend currently, and I just heard a newer facility in San Antonio is closing their dementia unit and opening a rehab unit because the reimbursement's higher. It's twice. Generally at Golden Manor, we go through a lot of deaths, and it's very difficult on the staff because we do have residents that have lived with us 12, 13, 14 years. And to support the staff, we do offer in-services, we do offer some counseling if they need that. We do try to support them in a lot of different ways with, monetarily and emotionally, because it is difficult. But it's just part of working in a long-term care facility. People will ask me or anybody else that works at Golden Manor, or really in any long-term care facility, why do you do that? Isn't it depressing? Well, I think that we do it because if we can contribute to the quality and comfort, security at the end of a person's life, to where that life, at the end of the life, is noble, I think that we've done our job. And that's what gets us through, and that's what gets us through all the deaths that we face and everything that happens, and all the crazy politicians that won't give us more money. And that's what we do. But you have to be, I think, a special person to work in a long-term care facility.
Question?
Sure.
Most of us here in the dental field
Uh-huh.
or hygienists. What about your dental care?
Well, okay, regulation states that we have to facilitate a resident to get to a dentist at least one time a year. I mentioned that we're 60% Medicaid. Medicaid doesn't pay for any dental care. We have sent people here to the dental school. We have a dentist that comes by and makes rounds. We also are having a affiliation with the school here, and Dr. Saunders will
Yes,
touch on that.
This is exciting news, actually. The state law says, actually it's the federal nursing home law, says that effective October 1 of 1990, that not only are the nursing facilities directly responsible for the dental care of their residents, but every state must provide at a minimum funding for emergency dental care for Medicaid residents. Texas went one step farther and passed a law, and in that law, it states that we can, that what's required is an annual exam, x-rays if the resident physically can handle it, and an annual cleaning. So Medicaid will pay for those three things for Medicaid residents. And what the nursing facilities are supposed to do is then charge the resident extra if they're Medicare residents or private pay residents. So that's how that works. And we got funded, actually, our Geriatric Education Center, which is putting on this course, has been funded with the supplemental project to conduct an interdisciplinary teaching nursing home. And Dr. Statmiller and I will be on site along with Dr. Sanchez Riley, who will be here, the next speaker, and Newstead, who you saw yesterday, the physical therapist, and Cheryl Statz, who you saw here a little bit earlier from nursing. We're going to have cross disciplines there. We're going to model for our students what a proper interdisciplinary team looks like and how well it should function, hopefully. and then we're hoping that we'll have master's dental hygiene students with us, and that's one of the discussions Magda and I will be having very shortly this week, because we have to put together an affiliation agreement with Allied Health to do that. So yes.
So when you say that that facility, the nursing facility, would charge the Medicare resident more money, are they charging them more money so that then they can turn around and make sure that they have the dental treatment?
That's correct. In other words, the state will not pay for a Medicare annual exam and all of that, only for the indigent Medicaid resident. So in order for a Medicare resident or a private pay resident to have any oral health care, they're going to have to fork over the money, or their families or whatever, which is a whole nother ball of wax we can talk about sometime.
Right. Well, we can talk about the lost dentures at
Yeah.
Golden Manor, and that happens. A lot of time they're ill-fitting, and the resident will leave them. They really don't want to wear them, and so they leave them someplace, and the facility ends up paying for those if the family, wants us to. Because it is our responsibility to help the resident keep up with the dentures.
And the thing you
But-
have to understand is that Golden Manor is exceptional in that way, because they are not-for-profit. They have a mission to increase their numbers of minority seniors, for example, and they're really focused strongly on fundraising and trying to make these kinds of things happen. So it's a good place for us to have an affiliation.
Yeah, we're a unique environment because one is we're small, and we're small, but we have a big building. We only have 6 semi-private rooms in the whole facility, so 68 beds are in their own. They have their own private room, and that's, I think, very important for all of us. When you get stuck in a nursing facility and you have this roommate, and they're maybe crying, maybe they're having some psychological problems, psychiatric problems, et cetera, et cetera. You don't really have much of a choice about who your roommate is. Certainly, there's an emphasis on resident rights, and resident rights are something that came out of OBRA, which Dr. Saunders referred to, and that's a federal legislation that governs nursing homes and really gave residents a voice in terms of how the homes are run and what rights that they do have. They have a right not to take their medication, for instance. They have a right to have access to a telephone. You think that would be, the right of everybody, but some of these things had to be enforced, unfortunately. We have a, and I hope that some of you will get to visit Golden Manor. You're welcome to come at any time and tour the facility. But we're very fortunate because we have a lot of space for our residents, and we're not for profit. We're not motivated by a profit margin. I'm glad board members aren't here today, but we keep our staffing ratios high. If you look on the paperwork I passed by, if you look on the CMS website, we have probably the highest staffing ratio in San Antonio. So we have adequate number of CNAs. CNAs do 90% of the work. If you don't have good CNAs they're doing the personal care, they're doing everything. LVNs are extremely important, test meds, et cetera, but the CNAs are your front line. If you don't take care of your CNAs, don't pay them properly, don't give them benefits, et cetera, then they're not taking care of your residents. So we're very fortunate to have these resources at Golden Manor. Not a lot of facilities do. You go into another facility, you go into a Medicaid room, and there may be 3 or 4 beds, Medicaid beds in one room. They're called wards. And their facilities, within 500 yards, maybe a little farther than that, very close to this building right here, that you can walk in and you'll find that. Last thing I want to say, and I didn't mention it before, is when you do your tour, the smell is the #1 indicator of the facility. And things you don't want to smell are a lot of perfume. It's really against regulation to use a lot of deodorizers and sprays to mask odor, or if there's a smell, if there's a urine smell. And you won't find that at Golden Manor because of high staffing ratios. We're actually changing them, we're taking them to the restroom, et cetera, every 2 hours or more often in some cases. And also, you know, we have a great housekeeping staff. Your dietary staff and your housekeeping staff are very important in terms of quality of care. Food is very important to people, to all of us. And if your food is not good, if your room's not clean, if there's an odor, you know, chances are that resident's not going to be a happy resident. And we're not going to want to work there. So it's very important, and you know, nursing facilities can achieve those goals. They can, and a lot of facilities don't in pursuit of the profit. You know, I understand that we have to have for-profit facilities, and there's some excellent ones. But don't ever put your loved one in a facility that has some of those problems.
Good question. First one is, you said you're nonprofit.
Mhm.
How do you make it with your nurses, RNs, LVNs, in the competitive salary?
Well, we start our LVNs at $18 an hour, and that's low. That's not. That's probably low end. We do have some incentives, some hourly incentives that we offer. We don't have any sign-on bonuses or anything of that nature. One thing, nurses like to work at Golden Manor because they're not going to be stuck with. They're only supposed to have 20 patients. That's what the reg says. But they're not going to be stuck with 30 patients and 1 aide to do everything. So we try to minimize. You know, we try to have a fair workload for them. But our highest turnover is in LVNs. I would say that we probably have. I've been in the home working as the assistant for 2.5 years, and there's been at least 100% turnover on our LVNs. It's very difficult. CNAs, it's not so bad. We have CNAs that opened the building in 1968. CNAs are in their 70s.
Boy, that tells you a lot.
Yeah.
For those of us who work in nursing facilities, especially in a city, the thing that happens the most is this huge turnover in CNAs.
Right.
And where you don't see it is in really rural areas where there's not a whole lot of
Yeah.
choices for them to move from one facility to the next, or in nonprofit homes that are really good nonprofit homes.
That's right. Morningside Manor is like us. They have a low turnover rate. Chandler, which is part of Morningside Ministries, Incarnate Word, St. Francis, those are all not-for-profits. McCullough Hall at Our Lady of the Lake is another not-for-profit. So you're going to see lower turnover rate in CNAs. But for some reason, it's really difficult for us to keep LVNs. And some of that is competition.
Question number 2, that new law that you were mentioning, your medication law, how's that going to affect all the nursing homes?
Medicare D? Well, I'm not sure yet. What I think is going to happen is that, say we have, I don't know, right now we might have 50 people on Medicaid, okay? Now those 50 people might have total 10 different programs that are administering their medications. So they might have program X, Z, Y, Z. Now we use Oakdale Farm, we have a contract with Oakdale to provide all our Medicaid medications. Now, Oakdale may not be a provider for program X, Y, and Z, so we have to use, you know, CVS as our pharmacy for those. It's going to make it much more complicated. It's going to be more complicated for us, and especially the LVNs, because they're the ones ordering the medications. And I don't know what's another thing that's going to happen is there's going to be more Medicare replacements moving into our market because of the drug benefit. Blue Cross Blue Shield is coming in, Aetna's coming in. So you're going to have Secure Horizons, Humana, Gold, Blue Cross Blue Shield, Aetna may have more Medicare replacements. So that's going to require us to have more contracts, and I think it's just going to make the industry even more convoluted than it is, even more confusing than it is. You know, in long-term care, you kind of have to be an expert in medicine and food and dental and physical therapy, occupational therapy, spiritual issues, and and especially legal issues, you know, advanced directives, durable powers of attorney, wills, all kinds of things that the adult protection representative was here. I've called it up protection just in the facility 3 or 4 times. When I worked in the home care, I bet my name is on in their system as a reporter probably 100 times. So it's a lot of different agencies to deal with in long-term care.
You mentioned that your aides have been with you all for a long time. You mentioned a couple of other facilities that also have great success with their CNAs. You also mentioned that about taking care of your aides. What do you think the biggest success or drive for your CNAs being there? What are some of the incentives that y'all use? And are you all able to have a higher pay scale because you're not for profit? How does that work?
Well, the pay, we're probably at bottom of the market in pay in terms of starting pay for CNAs. I think they're starting like $825 now, $850. Upper end CNAs make up between $12 and $13 an hour. This is someone who's been there since 1968, so it's not significant. I think what we do offer is that we have a very, like today, you know, it's Spurs play tonight. Okay, well, they're having a big Spur, you know, all the employees have Spurs stuff on. There's a lot of cohesiveness around this championship, and there is every year, depending on how they do. But we have a lot of, there's a lot of nepotism. A lot of people have married throughout the years, or a lot of families that work, you know, so that's one thing. We do offer bonuses at the end of the year, and they're based on performance. We do have a perfect attendance bonus. We do different staff appreciation parties and things throughout the year. We have Golden Manor t-shirts. So we do some of the superficial things, but I think what we do best is our interpersonal communication and relationships that we have with the employees. I think that, you know, we have all of the administration has open door policy. It's a flat organization. We're not authoritative in our leadership at all. And it's more of a family atmosphere. Is that good?
I think you really hit it, because I told you I used to teach nurses' aides, and I always heard from them, oh, I want to go to, you know, the Jewish home, and I'd hear that a lot, and I'd ask them why, and that would be the exact same reason, because everyone cares. The RNs and the LVNs don't order me around like I'm just a maid.
Right.
They make you feel like you're just one of them. They know that they're superior to them. It may have to do with their goals, but if you can make that connection,
Right.
and all those other things is an added plus. I mean, you could get one or the other someplace else, but
Sure.
having both the superficial things and the camaraderie,
Right.
and encouraging these group of people. Don't leave that other person out. Make sure you include them. In other facilities and some of the places I've taught, you can see separation. And if you don't have 2 people working together, there's going to be a resident who gets left out.
Exactly.
Who's forgotten.
Or dropped, or something.
10 residents supposed to be in hallway A,
Yeah.
and there's only 6 there. Well, what happened to the other 4? Because these 2 groups aren't talking.
Exactly.
And one of the things I try to teach them is you're not going to get anything done if you don't work together.
Exactly.
You've got to work together. And the only person who can do that is one of the superiors, the LVNs or the RNs, because they really don't have the skills to communicate, to facilitate that kind of relationship. So
Yeah.
you've got that, you've got the LVNs to do that,
Right.
whether they like it or not.
Not, so they have to. And some will step up and do that, and some are just going to concentrate on their treatments and their meds. But I think that, you know, we do have somewhat of a hierarchy, and we have senior aides on each station, and they kind of help us with the scheduling and what's going, and the politics. You know, we may have a problem on a station, the aides aren't getting along. Well, we just may have to move one of the aides to another station where she fits in, or he, well, actually we don't have any male aides. She fits in better on that team because of personality differences, etc. But it's very important, I think, that you nip some of these problems in the bud, or, you know, a patient, the resident's going to suffer ultimately. And, you know, we certainly don't want that to happen. Any more questions? Anything you'd like to ask? Again, I encourage you to come by Golden Manor. It's at 130 Spencer Lane, corner of Vance Jackson and 10, across from the Blood and Tissue Bank.
Let me raise a few things while you're still here and
Sure.
while we still have time. Last year, we had a couple of physician's assistant students in this group. And one of them stood up and talked about the project that they were doing as a class. And they started this project in which they are helping the Pharmacy Association get all of the seniors in the city to have and carry this long list of all of their meds and to have it in the house where it can be found by EMS if necessary. And it's a really neat project. And the hygiene students who were here last year said, we want to do a project. And we didn't take it that next step because the faculty member in charge at that time has moved on to another job. So we've got Magda de la Torre here. We're ready to do our affiliation agreement for dental hygiene with this nursing home who wants us there.
Yeah.
It's time for you guys to like get together and talk about what it is you might like to do. I will be the sponsoring dental person along with Susan Statmiller. Dr. Statmiller will be the two dental faculty, quote, who have to be on there along with your dental hygiene faculty member, whether it's you or another of your colleagues. That's my mission to you guys. That's my assignment for you to get together, decide what you want to do. Do you want to do a family education project? Do you want to do a CNA education project? Do you want to do a resident education project? Whatever you want to do, you dream, we'll make it happen as faculty. That's our job. Okay?
Coordination is the major cause of weight loss in any facility. So we would love any of those projects at Golden Manor.
Right.
Any facility would.
And we will have portable dental equipment on site. In fact, Dr. Statmiller, you and I are very late with purchase. We have a $20,000 unit we have to purchase for this activity. And Golden Manor actually has a room ready for us that we've got to go outfit, tell them what it is we want to put in there.
Let's go shopping then.
We can go shopping. So we will be doing some care on site. I highly recommend hygiene care. And we also have the geriatric dental clinic here who has agreed to take those residents that we're not going to treat on site. Yes?
I've actually met with Susan, I don't know if she remembers, we went out searching for a place for my dad. And
Oh, yes.
and it's everything you said about the
Yeah.
facility, I'd say twice as much.
Yeah.
It's a wonderful facility.
Thank you.
The only reason why we didn't go there is because my dad had started to have some mini stroke. And so I was a little concerned about it. If you wonder, and I know that you don't have.
Right, we don't have a locked door, yeah.
And that was the only reason.
But they're fundraising and eventually they're going to move. So they will have
Yeah.
a locked door in the future.
That was the only reason I went to be
Yeah.
Otherwise, that was our first choice.
Yeah.
Yeah. I just in fact talked to, well, Golden Manor Homes is a network, obviously around the country, and they have a home also in Dallas. And I just talked to a colleague who was looking for her grandmother, and they interviewed 36 nursing homes in Dallas, and they're not Jewish either, and they're Baptist, very religious Baptists, and they selected the Golden Manor home in Dallas, which was kind of interesting.
Yeah.
Yes.
This is kind of off and different, but I just have a suggestion, and I've been told many times that they lose the dentures because they didn't know who to give them to, because you can't try them on. It's not like the Cinderella slipper thing. So, is there somebody that you could put their initials or an ID name on?
Another project for the
Yeah,
dental
we could do
hygiene
that,
folks. Denture labeling.
Yes.
This is how you do it. It is so easy. Nail file. You get the heel of the denture up by the tuberosity area. You use the nail file. You roughen it up. You get a Sharpie marker. You put in the person's initials. You get Sally Hansen's Hard as Nails acrylic clear nail polish. Paint it over. That lasts for 6 months.
Okay.
I don't know if this is a
Labs
legend.
now allow
Yeah, they have to put it in there.
What's new ones? That's only new ones,
Yeah.
okay?
They're losing them
So
yourself.
all the old ones, there are people there who've had dentures, the same ones for 20 years. They probably haven't fit for the last 15. And all it takes is one really good-hearted CNA who collects them all to clean them and then doesn't know where they go back, you know? So
We
if
try
that's
that.
another great service in addition, you know, as part of your
Yeah.
project.
Yeah.
I'm not sure the nurses will let you use anything related to a marker close to the body. You know, we used to label the IV bags with markers and we can't do that anymore. So maybe.
Well, we'll find out.
Yeah, we'll
So
find
we can
out.
certainly
Yeah.
find out. It's a very commonly used technique. Another one that we could do is type it out on thin tissue paper and actually drill it in
Yeah.
and then lay it in there. You'd still have to glue it in and then cover it with acrylic, but we could do that, clear acrylic. Okay, any other questions or thoughts? How many of you have a relative in a nursing facility now? 2. Grandparents or parents?
An aunt.
Aunt. How about you? Grandmother. This is a relatively young
Group, yeah. It's hard. I had my great aunt was in a nurse, well, actually, my grandfather, my grandmother, and my great aunt were all in nursing facilities. And, you know, of course, they took care of their parents. And in our generation, we don't tend to do that. I think that's going to change as the boomers age and we don't have resources to take care of everything. People are going to do more home care. We're going to force to be doing more home care because of affordability.
Yeah, I think our sandwich generation is going to increase rapidly in number. And there are the people who are like myself, where I was taking care of both my father and my children in my home. So there will be lots and lots of those folks.
There's going to be there's another bill that's real big in California, and it's barely, not even just starting here. And that is nurses themselves are just bringing family members and non-family members into their home, and making it like a mini.
Yeah,
the board-
personal care home.
Yeah, like the
Yeah.
board and care homes.
Yeah.
And because it does bring in some money, but, you know, they bring in 2 or 3 people, and that's gonna, I see personally, that's gonna be the only answer. It's just going to be too many people.
Yeah.
Oh, those are some things to
Explore,
consider. And I'm telling you, you know, it's out there. And as we had that, I overheard Dr. Statmiller talking with Dr. Alstad yesterday when they were talking about, he's the rat research guy who really does all this wonderful stuff on longevity and aging. And she and he were talking, and she's saying, you know, I'm not so sure we really want everybody to live forever.
Oh.
Is that a really good thing or
Yeah.
not? And we were talking about the fact that, yes, we want to be independent as long as possible, as old as possible, healthy, and then just fall over one day. Okay, well, that's not going to be the reality. And somewhere in there, even if it's those last few months of our lives, we're going to need home care, if not institutional care. It's going to be so expensive when you folks are old enough to need it. So long-term care insurance is definitely the way to go, and the best part is the younger you are when you buy it, the cheaper it will be, and the rate will not go up. And you just, you know, buy a good plan that has inflation built into it so that you won't be paying $11 a day for care that all of a sudden costs $180, you know.
Yeah.
So that's my best advice for your future, which is a horrible thing to have to think about when you're as young as you are, but you need to.
The statistics show that by the age of 33, 33% of the people are disabled at least 6 months time, sometime around that time. So that's a good time at 33 to start thinking about getting
In
this
your early 30s, yeah, when you've got your job, and you're
If you're
set.
disabled, you can't take care of yourself.
Okay.
Well, thank you for all of
Anything
your
else?
questions.
That was excellent, thank you.